On the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. We're all human, and it's important to know that doctors are people too. Doctors have emotions, they have passions in life and hobbies, and they enjoy participating as active members in the communities where they practice medicine. Doctors have families, friends, and relationships, while the latest in healthcare and the most current treatments for ailments will be topics on this Doctors Are People Too radio TV show. The focus will be in learning more about the interesting aspects in a physician's life and what they do away from the doctor's office or operating room table.
Hello, South Florida and beyond, and welcome to Doctors Are People Too on Monday, February 27th, 2017. We have an action-packed program tonight. We have a neurosurgeon on the show from Sunrise Medical Group and Florida Medical Center, a campus in North Shore and Fort Lauderdale. Dr. Oken, welcome to the program. How are you?
I'm very good, thank you. How are you doing?
Thank you, and it's Dr. Jessica Oken. She's a neurosurgeon with Sunrise Medical Group and Florida Medical Center, a campus of North Shore. Yeah, thanks for taking the time to be on the program. I realize you are super busy, and we actually texted this afternoon. You were actually doing a surgery this afternoon, so I'm glad that you were able to make it on the program.
So am I. Thank you for having me. I finished surgery in the nick of time.
Oh, thank you. Now, getting right into it, is it true that most people think of neurosurgeons as brain surgeons? And I obviously wrote that question. That's what I thought without knowing too much about it. But is that a common occurrence?
Yes, and that brain surgery is a large part of what neurosurgeons do. However, we also perform a lot of spine surgery. And there are many neurosurgeons that only do spine surgery and no cranial work. But brain surgeon is certainly the way we're commonly thought of.
Now, with neurosurgeons, I also realize that all of you don't specialize in the same areas of interest. You kind of are specialists in different aspects of neurosurgery. So, loosely defined, is neurosurgery any surgery performed on the nervous system?
Yes, that's a pretty good way of putting it. Certainly there are subspecialists in the field of neurosurgery, some that only do vascular or pediatrics or trauma, spine, tumor, or just some of the different subspecialties, but many of us are general neurosurgeons.
And of course, neurosurgeons operate on the brain, correct?
Yes.
What about the spinal cord? Do neurosurgeons provide surgical treatment for the spinal cord?
Yes, we do as well. Usually it is surgery to decompress the spinal cord, to take the pressure off of it, which can be caused from severe arthritis and disc herniations. Less commonly, though, neurosurgeons also perform surgery for removal of spinal cord tumors or vascular malformations and are actually working within the spinal cord.
Okay, so decompress to take the pressure off, and then also in some cases, I imagine those are some more of your rarer cases, spinal cord tumors.
Yes.
Is it correct to say that neurosurgeons perform spinal operations involving the discs and nerves, while, say, an orthopedic surgeon, back surgeon would treat the actual bony spine?
Not quite. There actually is a degree of overlap between what orthopedic spine surgeons and neurosurgeons do. Both neurosurgeons and orthopedic surgeons will treat the bony spine and do procedures such as spinal fusions for degenerative pathology or for deformity. And we also, there are many orthopedic surgeons that work on the discs as well as neurosurgeons. However, for the most part, the neurosurgeons are performing surgery on the nerves directly, not the orthopedic surgeons.
And the way I understood this recently was actually when I did a little bit of research on David Wright, the New York Mets third baseman, and the cervical surgeries he had to have it. While doing my research, I found that he sought the care of a neurosurgeon and had surgery, so that kind of helped me, the sports side of things, when I thought initially it was going to be an orthopedic spine surgeon. So sometimes just using the world of sports, something I'm very in tune with, helped out. Let me ask you though, do neurosurgeons also provide care for the peripheral nerves?
Yes, some of us do as well. Most commonly, we can do surgeries for carpal tunnel decompression, but also sometimes for peripheral nerve tumors, and also for injury to like the brachial plexus, which is the group of nerve roots that exit from the neck and go into the arm.
I see. And can neurosurgeons provide treatments for the cerebrovascular system as well?
Yes, we do. For the vasculature that perfuses the brain, the spine. Actually, one of the surgeries of the cerebrovascular system involves operating on the carotid arteries, which are the largest blood vessels going to the brain. And I did that surgery today, and that was for stenosis, when plaque builds up within the vessel. Oftentimes, especially in South Florida, that's a surgery that vascular surgeons will perform. However, neurosurgeons are also trained to perform surgeries on the carotids as well.
And I was going to ask you before, but I was going to see if you were going to offer it. I didn't want to ask you too much about the case, but yeah, that was for a carotid artery. So if that wasn't taken care of, could that have led to a possible stroke or some other type of ailment in the brain?
Yes, that's actually the indication for doing surgery is to prevent stroke.
And were you called in emergency, or was that something that was scheduled?
It was something that was urgently scheduled.
Okay. Thanks for sharing that with us. I know you can't tell us too much, but I really appreciate that, because it really, helps out in understanding, the care that neurosurgeons provide. And we're here with Dr. Jessica Oken. She's a neurosurgeon with an office at Sunrise Medical Group. That's Sunrise Medical Group, 3540 North Pine Island Road in Sunrise. That's just north of Oakland Park Boulevard on Pine Island Road. I've been there a few times. The number's 954-653-3722, and the website is sunrisepractices.com. And Dr. Oken is on staff at Florida Medical Center, a campus in North Shore in Fort Lauderdale, and another local hospital in Broward County. And actually, Florida Medical Center is about less than 2 miles east of Dr. Oken's Sunrise Medical Group office. So convenient in the area right there. Great location, easy to get in and out of. Dr. Oken, we talked briefly about spinal cord tumors. One of your main areas of interest on the website is brain and pituitary tumors, including endoscopic approaches. How do you provide neurosurgical treatment for brain and pituitary tumors, and what are the endoscopic approaches you use to treat these tumors?
Okay. So for the most part, when neurosurgeons perform brain surgery for a tumor, they will do something called a craniotomy, and that involves removing a small window of bone in the location most suited to access the tumor safely. However, pituitary tumors are located at the anterior skull base, which is the base of the skull really right behind the sinuses, deep to the nose. And so that requires a large incision if you're going to reach it from one of the traditional approaches. So a more common approach for pituitary tumors involves going up through the nose. And that traditionally is done with a microscope. However, with the advent of the endoscope, which is a camera, it allows us a wider field of view and allows us to tackle larger tumors in that area. And the scope is placed up the nose, and we enter the base of the brain through the back of one of the deeper sinuses in the face, the sphenoid sinus. So it's called a transsphenoidal approach.
Now, that is, it sounds like it's a little less minimally invasive than an actual going through the actual skull bone itself, so that the endoscopic approach, would it be safe to say, is more minimally invasive?
It is more minimally invasive from an approach standpoint than doing a large craniotomy. However, you do have to go through the base of the skull, but it's a more direct route to the pituitary, and it involves just removing a smaller portion of bone on the back of the sinus where the pituitary is on top of.
Oh, wow. That is fascinating stuff we're getting here on Doctors Are People too. Now, also, another one of your areas of interest is revision spine surgery. When is revision spine surgery necessary?
Well, there are several reasons people need to have revision spine surgery. The most common is like a recurrent disc herniation. So you have a disc herniated in your back, you get better from the first surgery, and then that shooting pain down the leg returns because the first time that surgeons will remove a disc, they often only remove the fragment that has herniated, and they leave the rest of the disc preserved. And so with improper bending or twisting, or sometimes just bad luck, a patient can re-herniate, and that will require revision surgery. Some of the other reasons for revisions is a process called pseudoarthrosis, and that's when a patient fails to fuse after a fusion surgery, and that can require further stabilization. Another pathology is something called adjacent segment disease, and that's when the area above or below the region operated on in the spine develops progressive pathology that needs to be addressed. So a disc herniation above the level of the fusion, for example. And then another reason for revision surgery would be hardware failure, if a screw breaks or pulls out. And that's less common, but it does occur.
And what is the recovery process? I know each case is different, but what is the recovery process for that type of surgery, a revision spine surgery?
It's generally similar to the recovery for the first-time spine surgery. It really just depends on how much tissue we need to disrupt to treat the problem. So it can range from anywhere from same-day surgery for a recurrent disc herniation. It could also involve 3 to 5 days in the hospital, and then a rehab stay. It depends on the patient's pathology.
And we're here with Dr. Jessica Oken. She's a neurosurgeon with an office at Sunrise Medical Group in Sunrise, Florida. The address there is 3540 North Pine Island Road. The phone number is 954-653-3722. And the website is sunrisepractices.com. Great website there with a ton of information. Dr. Oken is on staff at Florida Medical Center at campus in North Shore and other local hospitals in Broward County. Dr. Oken, we're going to take a quick break, but on the other side, I want to talk to you a little bit about cranial and spinal trauma, and also a little bit about Sunrise Medical Group, your education training on Doctors Are People too.
Hi, my name is Dr. Rahul Agarwal. I'm an interventional cardiologist in Jupiter, Florida. I did my medical school at the University of Florida and my internship and residency at the same program. I did my chief residency also at Shands, and then did my cardiology and interventional cardiology at Wake Forest University in Winston-Salem, North Carolina. I specialize in general cardiology, interventional cardiology, and nuclear cardiology. Even though I'm an interventional cardiologist, the majority of my practice involves general cardiology. General cardiology is a pretty broad spectrum in that it involves rhythm problems such as atrial fibrillation, heart disease such as coronary artery disease, congenital heart disease, high blood pressure, and cholesterol problems. I do procedures such as cardioversions, which involve trying to convert the patient back to a normal rhythm if they have an arrhythmia. Also deal with plumbing problems such as the coronary arteries, which if they're blocked, I can do angioplasty and stents, which involves balloons that open up the arteries. And these stents act as scaffolds that keep these arteries open. I really do believe in preventive medicine, and one of the areas that I really focus on is diet. One can really get caught up on the pills aspect and the exercise. And diet we talk about a lot, but unless one really has some guidance as to where to go with diet, it can be quite difficult. So I do give my patients homework in terms of books or movies that they can rent or obtain so that they can get educated. Our cardiology office is located in the Abacoa area of Jupiter, Florida, conveniently located between two of the local hospitals. We provide echocardiography, stress testing, ultramonitoring, and general cardiology office visits. We really pride our practice in its staff, who are very courteous and professional. We believe that under our care, you'll feel the same way too.
Tenet Florida Physician Services is a multi-specialty physician group providing care to the communities of Palm Beach, Broward, and Miami-Dade since 2007. The TFPS team is committed to delivering quality care. Our mission is to improve the quality of life of everyone who walks through our doors. Today, we are proud to be one of the largest and most respected physician networks in the area. To learn more about Tenet Florida Physician Services, visit tfpsdocs.com. That's tfpsdocs.com. Or to find a doctor, call 1-866-654-2362.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
And we're back on Doctors Are People Too with Dr. Jessica Oken, a neurosurgeon with Sunrise Medical Group. Dr. Oken, it is Oken, right? I never really asked you, but I've heard people say Okun as well.
It's Oken, yes.
Oh, good. I'm glad you never corrected me, so I was hoping that I was on the right track there.
You nailed it.
Awesome. Thank you. How does, let me ask you a question. How does neurosurgery relieve cranial and spinal trauma?
Well, the primary purpose with both cranial and spinal trauma is to decompress the brain or the spinal cord. So if somebody has a large hematoma or an unstable spine, we want to decompress to protect the brain or spinal cord and then stabilize, which would involve fixing any skull fractures or spinal fractures.
And that's also one of your areas of interest, cranial and spinal trauma, correct?
Yes, I had a very heavy training with trauma in my program, and it certainly is a passion. It's exciting to save someone's life, and oftentimes it's exhausting because it involves operating in the middle of the night. However, it's certainly worth it.
Why in the middle of the night? Is that because there's more trauma cases, or is it just the time when that sort of trauma happens?
Oftentimes it's a car accident in the middle of the night, or it's just the nature of the beast. It's not always in the middle of the night, but invariably you get called in 2 o'clock in the morning for someone with a head bleed.
Oh, wow. Now, if I'm referred to a neurosurgeon, do I need to have surgery, or are there non-surgical treatment options? Obviously, coming off a trauma call, that's not a non-surgical treatment options. But, if there's a different kind of ailments maybe if I was to see you in the office, are there non-surgical treatment options neurosurgeons can offer, or is it, once you see a neurosurgeon, you're on the path to surgery?
No, not necessarily. Oftentimes, especially in spine patients, the primary symptom is pain, as opposed to a true neurologic deficit, such as weakness. So in that case, when somebody is coming in for a neurosurgical consultation for pain, we try to guide them through the gamut of conservative treatment options prior to offering surgery. And that may involve anti-inflammatories, steroids, muscle relaxants. It may also involve injection therapy performed by anesthesia pain medicine physicians, physical therapy, and then, of course, there are other holistic treatment approaches that we can refer patients for, such as acupuncture, massage. And then it's only when patients have reached the end of the line and have failed conservative therapy and their quality of life is significantly impaired do we offer surgery.
Now, in terms of seeing a neurosurgeon, what types of medical specialties typically refer patients to neurosurgeons?
Well, for spine, it's generally pain management physicians or neurologists. However, from the cranial end, we can receive consults from endocrinologists who diagnose pituitary tumors, cardiologists for carotid disease, but I would say our primary referring doctors are the neurologists.
And then also, do primary care ever refer to neurosurgeons?
Yes. Yes, they do.
Now, you mentioned neurologist, and sometimes if you're not in the medical, the healthcare business, it's tough to make a difference between. But what is the difference between a neurologist and a neurosurgeon?
Well, neurologists treat disorders of the nervous system that include brain, spinal cord, nerves, and they can recommend a surgical treatment, but they don't actually perform the surgery. But they are often key in the diagnosis of these disorders, whereas the neurosurgeon actually specializes in the performance of surgical treatment of brain or spinal pathologies.
I see. And neurosurgeons and neurologists work together to provide comprehensive care to an individual in certain aspects?
Yes, absolutely. We have a really great team at Sunrise.
Now, your office at Sunrise Medical Group is primarily neurologists, except you and your colleague, Dr. Gil Pastorin, who's also a neurosurgeon. Talk to me a little bit about the team of working with Dr. Pastorin and then also a large group of neurologists. We lose Dr. Oken? Okay. So we're on the program with Dr. Jessica Oken. She's a neurosurgeon with an office at Sunrise Medical Group and sunrisepractices.com. Her phone number is 954-653-3722, and her address is 3540 North Pine Island Road in Sunrise. It's just north of Oakland Park Boulevard there on Pine Island Road. And Dr. Oken is also on staff at Florida Medical Center, a campus in North Shore in Fort Lauderdale. And she's on staff at another local hospital in Broward County. Florida Medical Center is about less than 2 miles east of Dr. Oken's Sunrise Medical Group office. So we've talked to Dr. Oken a little bit about difference between neurosurgery and brain surgery, and as well as okay, Dr. Oken is back on. Dr. Oken, are you there?
I'm here. Sorry I lost you.
No, that's fine. We were just talking about the group of neurologists, of a large group of neurologists, a team of neurologists at Sunrise Medical Group. Now, what is a typical day in the office for you, like at Sunrise Medical Group? Is it mostly consultations, follow-ups? Do you do some testing there? I believe there's MRI on site.
Yes, we have MRI on site. We have physical therapy, and we also have the neurologist doing EMG and nerve conduction studies. But a typical day in the office for me involves seeing new patients in consultation, seeing post-ops, and then if some who would be referred for conservative therapy, and others that would get signed up for surgery.
And what about turning it 180 degrees? What's a typical day like at the hospital? Do you spend a lot of time on call? You said before you do get called in for trauma calls.
So Florida Medical Center is not a trauma center, so we rarely have any trauma coming through there. But I am on call 1 out of every 3 days, an average of about 10 days a month. And a typical day involves seeing the patients in the ICU first, because they're our sickest patients, and then visiting post-ops on the floor, new consults. And then surgery generally starts around 7:30 or 8 in the morning.
Okay, Dr. Oken, we only have a couple more minutes, so I'm going to tell everyone if they'd like to learn a little bit more about your education and training, sunrisepractices.com is a great way to get started there. You can get the phone number, address. But I really wanted to ask you about, can you talk about your interest in medical student and resident education and in promoting neurosurgery?
Absolutely. Many people are of the misconception that that neurosurgeons have a terrible lifestyle. But the majority of neurosurgeons I know are passionate about what they do and enjoy their work. And when they're not working, they really are trying to get as much of a bite out of life as possible. And most of them have very interesting hobbies and enjoy travel. So one of the things that I try to do when I'm working with medical students, especially as a female and a new mother, is I try to encourage medical students that you can have a life and be a neurosurgeon. You don't have to work 100 hours a week and never have time for a family. There is a way to achieve a work-life balance. And it's also to really expose the medical students and residents to the new technology and the various surgeries that we perform, because a traditional medical student rotation does not include shadowing or working with a neurosurgeon. So many students graduate medical school without ever having actually spent a day in the OR doing neurosurgery, and it's a fascinating field. We take care of pediatrics and adult patients. We treat tumors, vascular disorders, degenerative disorders. It's really a great career to make a difference in a person's life, and I wouldn't trade it for anything. So I just like to have the opportunity to share my passion with medical students and residents as often as possible.
And we're here with Dr. Jessica Oken, neurosurgeon at Sunrise Medical Group. Dr. Oken, thanks so much for coming on the program, and I really look forward to having you on again in the future.
Wonderful. Thank you for having me. I really appreciate the opportunity to share a bit about my day.
That was great. Thank you again for coming on Doctors Are People Too.
My dad is a cardiologist, and so I have two brothers, and we were all equally painful to my mom. And so to get us out of the hospital, we would go on rounds with him on Saturdays and Sundays in the hospital back in Oklahoma City. And we used to, race wheelchairs down the hallways from the time I was about 6 years old. When I was a freshman in high school, I got to watch my first heart transplant. But I think what really kind of made me want to be a doctor was around the holidays. The house always filled up with tons of gifts from thankful patients. And to impact people's lives like that in a positive
What is AFib? So in the realm of heart disease, there's several things that can affect the function of your heart. Okay, one of those are arrhythmias, and arrhythmias are just when your heart beats either too fast or too slow or irregularly. Okay, one of the most common arrhythmias is the one called atrial fibrillation. The heart has four chambers, two upper chambers and two bottom chambers. The upper chambers are the atrium. And when these chambers start beating abnormally, okay, that's when instead of having a normal contraction of the atrium that contributes to the cardiac cycle, then the atrium start just quivering or shaking, and that's what's called atrial fibrillation. When this happens, the coordination between the upper chambers and the lower chambers of the heart is lost, and that as a result is going to bring some more problems, and in the long run is going to create changes in the actual tissue of the heart that is going to create even more problems like heart failure.
And how common is AFib?
Here in the United States, we have approximately 3 to 6 million people that suffer from heart failure. And some of those are diagnosed, but many of those are not diagnosed yet. And that's the problem. One of the big dangers of atrial fibrillation is that it increases your risk of having a stroke. Just by having atrial fibrillation, increases your risk of having a stroke. And many people are walking with atrial fibrillation without knowing, because up to 40% of people will not know or feel any symptoms.
So what should a person do? Because, working at the hospital and walking around and talking to the different people in different departments, there's one woman that comes to mind that looked at me one day and said, I think that I have AFib. So how does a person know when they should really go see a cardiologist to find out what it is that they have?
One of the most common symptoms for atrial fibrillation is fatigue. And atrial fibrillation, is most commonly found, and it develops over time with age also. So it is not uncommon to find patients that say, you know what, doctor, I've been feeling a little tired, and that fatigue is just getting worse and worse and worse. But they think this is part of their aging process, right? They're in their 50s, they're in their 60s, or late 60s, early 70s, and they say, well, I always thought that this fatigue and tiredness was because I'm just, older and older. And if you make your annual checkups, an electrocardiogram should be part of it. And as doctors, or your doctor will know whether or not you're in atrial fibrillation just by taking an electrocardiogram. Some of the other symptoms that you might feel is palpitations, the feeling of something fluttering on your chest, or that your heart is beating too fast or too slow, or you can actually feel it on your chest, pumping on your chest. That's also very common. But patients can have just a little dizziness, okay? They can have even what we call syncope episodes, which is, loss of consciousness momentarily. If any of those things happen, you should first call 911, go to a hospital, and if it's not an emergency, they should call your doctor, make an appointment with your doctor so they can get checked and get one of these electrocardiograms.
And I remember you and I have worked on a lot of stories together, and I remember mentioning to you a personal matter of mine, and you said you should definitely come see a cardiologist when I did the EKG, and we spoke about it. So what is it that you want the public to know about seeing a cardiologist?
It is important for patients to be referred to the specialist that will take the best care of that problem. If you have been diagnosed by, let's say, your primary care physician because they did an electrocardiogram and they saw atrial fibrillation, the next step is to be referred to a cardiologist, which is a specialist that only sees patients with cardiac problems, heart problems, right? So that's the best thing that you can do. You ask your primary care physician to be referred to a cardiologist, because the cardiologist will make a more extensive workup and see how much of a problem do you have. And if you do have atrial fibrillation, and you cannot be managed only with medications, then they might need to refer you with another specialist, in this case a cardiologist that specializes only on electrical rhythms of the heart, which is an electrophysiologist, to see what the best options for treatment would be.
And who are the people that are most at risk at getting AFib, would you say?
As I mentioned before, some people just with aging, that's one of the risks. That's a higher risk. The other population is overweight, people with problems of weight, body weight, people that develop sleep apnea, okay, and people that have some. In order for you to have atrial fibrillation, you have to have some sort of change in your muscle, in the actual muscle of the atrium in the heart. So people even with illnesses like heart failure, over time they stretch their chambers, their heart, and that creates scar tissue in the actual muscle of the heart, which we call fibrosis. And this tissue does not conduct electricity normally. So we know that the heart has a very, very predictive pathway, electrical pathway, and that's how the heart contracts, right? Because there's specialized cells in the heart that develop the capability of producing an electrical impulse. And this electrical impulse is going to go down a very definitive pathway or normal pathway to create the proper environment to develop a heart contraction, a normal heart contraction. But when there's scar tissue already in the heart, on the muscle, on the atrium, this scar tissue will interfere with the way that electrical impulse travels down from point A to point B where it should go, and starts creating other foci of abnormal electrical impulses. And that's what creates the problem. And the more it lingers, over time, the more the chambers enlarge, the more fibrous tissue the patient develops, and the harder the atrial fibrillation is to control.
And I want to mention to everyone out there that's watching us, that's listening to us, that Dr. Galindez is at Florida Medical Center, and he is going to be participating at an AFib symposium that's taking place Thursday, February 23rd, and he's going to be with Dr. Byer and Dr. Nairi, who he also works with, and I'm going to have him talk a little bit about that. And this event is taking place at 1801 Northeast 6th Street at 12 p.m. at Emma Lou Olson Civic Center. So you want to come hear about AFib, you want to come meet Dr. Galindez and Dr. Byer and Dr. Nairi, please come and meet us there at noon on February 23rd. One of the things I wanted to talk to you about is we sit in the cardiology meetings. And I have personally learned how all of you work together. And I wanted you to explain and talk a little bit about that so the public understands and the community understands that this is not only, they're not only getting the service of perhaps one doctor, they're getting the service of several doctors that all work in a cohesive manner.
Yes, we do have a very comprehensive service for heart disease, including the arrhythmia and the atrial fibrillation program that we have at Florida Medical Center. Is the surgeons, Dr. Byer and myself, and the electrophysiologists like Dr. Nayeri that take care of these patients. And what usually happens is if we get a referral for atrial fibrillation, usually it's going to be seen by one of the cardiologists that will refer that patient to the electrophysiologist. Once the electrophysiologist sees the patient, they determine what the best options of treatment they have, either medication or some of the least invasive procedures like catheter ablations or cardioversions. When the patient has atrial fibrillation, has had atrial fibrillation for a long time, that is called a persisting atrial fibrillation or long-standing persisting atrial fibrillation, then it's really hard, as I explained before, to control this kind of ailment. So what we need and what we have in Florida Medical Center, we have developed the program of the hybrid ablation program. And it's called hybrid because it takes two specialties. It takes the cardiac surgeons on one part and the electrophysiologists on the other part. and we both both specialties work together to get a better ablation and better results in the long term for these patients. So it is a team of physicians. It's not only one physician that decides what to do or what's the best option for this patient, but we all see the patient and we determine what the best treatment plan should be.
And I also want the community to know that Florida Medical Center and Dr. Galindez, along with all the other doctors, are very involved in the community. And recently we had 50 students from an area high school, and Dr. Galindez was in surgery. He finished his surgery and rushed to the conference room to attend to the 50 high school students that were there. And they got quite the surprise because they were able to dissect a pig's heart. So I wanted you to talk a little bit about that experience and what that experience meant to you of being with those students.
Yes, thank you. The program was started and has been developed by Dr. Eric Bayer, which is the director of the cardiac surgery program in FMC. And that day, there was a group of high school students that arrived at Florida Medical Center. And thanks to the Medtronic company that brought the actual tissue, the hearts, these are real pig hearts. They brought them to Florida Medical Center to show the students and to divide them into several tables and to show them kind of anatomy and physiology and just have a hands-on experience of what it is to what we do in the OR. And that was a great experience for them. There was an article.
It was amazing.
So they were. We asked them what they thought about the program, and they said that it was amazing because they've never done something like that before. And it was great to see these young minds trying to comprehend what we were telling them about the heart and actually have the specimen in their hands and being able to work on it. So it was a great experience. We'll keep doing that. That was a great experience for everyone.
Yeah, thank you. Thank you for doing it. I felt the energy there, and the students were very excited. The staff was very excited, and I'm really looking forward to the next one. Moving along, you and I talked about last week, we wanted to talk about heart failure. Because a lot of people don't understand what goes into heart failure. So can you talk a little bit about that?
Yes, as I mentioned at the beginning of the program, heart disease is a realm in a spectrum of illnesses. One of those, and probably the most common one everybody knows, is about coronary artery disease. And actually, if you look at the American Heart Association last update in January 2017, just last month, probably about 45 to 48% of heart disease is coronary artery disease. This is blockages in your arteries. There's a smaller part, though, which is heart failure. And heart failure is just a decrease in function and the ability of your heart to effectively pump that blood all the way through all the vessels in the body. And when the heart, the muscle weakens and the function decreases, that's called heart failure. That can be caused by many things. One of the things it be caused by is coronary artery disease, having blockages on those arteries. And as surgeons and cardiologists, we have been really great and successful at treating these patients. The more patients we treat, the more survivors of ischemic heart disease or coronary artery disease we have. At the same time, because of those patients are surviving more and more, we have a growing population of patients with heart failure. Over time, some of these patients develop heart failure, that decrease on the function of the heart. So that's one of the causes. It could be caused by coronary artery disease, or it could be caused by infections, like viral infections, okay? And sometimes we don't know what's causing the decrease in the function, and we call it, we don't know if it's an infection, we don't know if it's a vascular problem, we don't know if it's some deposits of abnormal proteins in the muscle, but the function just decreases. Now, as I said, the population here in the United States of heart failure patients is increasing. The treatment for those patients, we start with risk modifications, trying to get the high blood pressure under control, try to get a good diet, low salt diet. If that doesn't work, then you escalate the treatments to use some medications, right? up to the point where you just need diuretics. So this is the medications that get rid of some of the extra fluid that your body has, and your heart cannot pump effectively, and all the way to the last stages of heart failure, which is when the patient already needs something given IV in a daily basis. And these are medicines that are called inotropes. And when the patient is on those medications, just to try to get that heart to pump effectively, but the patient is dependent on those medications, then we are at the last stages of heart failure. The next step from that would be heart transplantation if the patient is a candidate for heart transplantation. And until a couple of years, there was no other option other than the patient going to a hospice if they were not eligible for a transplant. Now, we have created the technology to actually help the heart pump that blood flow again effectively throughout the body by the use of certain devices that we can implant. These are called ventricular assist devices. And these pumps, that's what it is. It's a pump that takes over the function of the heart by implanting this pump inside the heart in the left ventricle if the failure is from the left side, or in the right side if it's from the right ventricle. And this pumps the blood through the device into a small graft that is connected to the main vessel coming out of the heart, which is the aorta, which in turn will circulate the blood all around the body. It has been amazing because since the early, if you take a look at a graph of how many hearts do we have available for heart transplantation since the mid-90s, we haven't been able to do more than about 2,500 heart transplants a year. So the pool of hearts available for transplantation has been stagnant since then, since the 1990s, mid-1990s, okay? And as I mentioned before, the population that needs hearts is growing and growing and growing. So that's where this new technology of left or ventricular assist devices, it's so important and takes place because then now we're able to support all these patients that cannot either wait for a heart transplantation because they're so sick and they cannot wait on a waiting list, or they are not candidates for a heart transplantation, but they are candidates for a device like the ventricular assist devices, and they can go for many, many, many years after the device is implanted, while before the other option would be hospice.
Are you seeing a difference between men and women when it comes to heart disease?
There are subtle differences, but there are differences. If we talk about coronary artery disease and symptoms, things that you need to know, right? Everybody knows about the chest pain, chest pressure, shortness of breath, maybe a pain radiating to the neck, to the shoulders. In women, it's a little more common to have things like nausea, like the pain down the back or on the back, or pain on the jaw or the neck, more than men. Why? We don't know why, but it's important for women there to know that if you start feeling a little short of breath, even without any chest pain, and you have any of these symptoms like nausea, vomiting, you get cool and clammy, start sweating, and a little discomfort on your shoulder or the jaw, as I said, even without any chest pain, then they should call probably 911 and get to the hospital to get checked. You never ever, if you're going to drive, you don't drive yourself if you think you're having a heart event, right? Because something can happen between your house or whatever the place might be and the hospital. Or you never ask anyone to drive you to the hospital. Just call 911, have the ambulance get there and take you to the hospital.
This show is called Doctors Are People Too. So I want you to tell me how it is one of your weeks, because every time I talk to you, you're very busy, you're running around. I see you in the hospital, you're running from room to room, from place to place, from meeting and going to meetings. So tell us a little bit so the audience understands what it's like to be in your shoes.
We have a very, very dynamic service, and our group is comprised by 4 heart surgeons and a very talented group of what we call mid-levels, which is nurse practitioners and physician assistants, and of course all the staff in the hospital, including the nurses. My week starts, let's say, Monday morning. If I have a case, I'll be in the OR. Usually the cases last about, it all depends on what case it is, but an average about 2 to, let's say, 4 or 5 hours. Okay? If there's a second case, then we go on with the second case. But if not, then it's time to go and check on patients on the hospital. The nature of the service is we have a lot of emergencies. So if they call any of us from any of the other hospitals, meaning the Ray Medical Center, Florida Medical Center, Palm Beach Gardens, even St. Mary's, then we have to go and assist and see what the problem is, what the emergency is, to see if the patient needs to be transferred back to any of the facilities where we have the heart program, and see if they need surgery emergently or not. And so we go and we evaluate the patient, and we make the proper planned treatments and decisions, and then we take it from there. And then, every once in a while you're on call. So if there's emergencies at night, in the middle of the night, then you get called, you have to go see patients. Of course, you're always going to be, they're going to be calling you because of the patient that you operated on that morning. They need to follow up and close follow up. So you're always on the phone and thinking about patients or calling back to the hospital, making sure that everybody is doing well or rounding on your patients.
Okay, is that my next doctor or is that a caller? Next doctor? Okay. Why did you want to become a doctor?
I was always inclined towards the science of all my classes, towards natural science, and then it became medical science. Then I knew when I knew that I did want to be a doctor. I was involved in pre-hospital medical care first. I was a paramedic. Mm-hmm. I actually was working for a 911 service in South Texas for a while. And so I knew that medicine was what I wanted to do. When I applied to medicine, I knew that it was going to be something hands-on, like surgery, right? And so when I applied to medicine, I remember in my essay for the application, I said either I want to be a trauma surgeon or a heart surgeon. And, throughout my medical school and going into my general surgery residency, I realized that I was just fascinated about how the heart works and how heart surgeons were able to actually stop the heart so they could work on the heart and still and start the heart again, and the patient will be fine. Mm-hmm. So that's where I decided that I wanted to be a heart surgeon. It was just fascinating to me to be able to stop the heart and work on the heart, and the patient will be okay.
And we're lucky to have you. We're very lucky to have you in our community.
Thank you.
And what is it that you do? You work so much, and I know you have 3 children in your family. What is it that you do for fun? Because that's what people want to know about you too.
So when I'm not working, we try to have a quality time. We try to, if we have like a weekend, we have to do like a short trip, and we like cooking. We like going to museums, and we try to be physically active as much as we can.
Okay. I want to mention to everybody that's watching and listening that Dr. Galindez is going to participate in an AFib symposium on Thursday, February 23rd at 1801 Northeast 6th Street. And this is at 12 p.m., Emma Lou Olson Civic Center. And we're just really excited to have you on board at Florida Medical Center. I mean, it's awesome to have you. It's awesome working with you. And thank you for everything that you do to help the community.
Thank you. Thank you for the invitation. And it is very important for people to realize if you have any risk factors for heart disease. As I said, if you do like hypertension, if you smoke, if you have diabetes, if you're overweight, if you have sleep apnea, then you should tell your doctor and ask for a referral to be seen by a cardiologist.
Thank you, Dr. Galindez.
You're welcome.
We'll be back.